I know, I just looked at her.
Alright, so today we're going to start with PA and lateral chest. For your PA chest, it's going to vary based on your patient as to how your image receptor is going to be orientated, okay? For average or large, you're going to go with crosswise. For skinny or really skinny, you're going to go lengthwise. Something that I kind of like to base my image receptor orientation on is based on my patient's shoulder width. Catalina for sure would be lengthwise, okay? But like Taylor and, oh my God, Lily. I was like, I haven't had you for a week and I don't remember your name. Okay. Taylor and Lily, I think that it would just kind of vary. You want to kind of look at them and look at your light field and decide where to go from there, okay? Connor would probably be lengthwise as well. All right, so we're going to go with crosswise here. If you're doing crosswise, you need to put your little doodad in there to hold your detector up. And make sure you get it in here, just so. And then don't forget that when you go to lateral, you have to change to lengthwise from crosswise, okay? I feel like that's like the biggest thing that people forget. So on my 72 inch, I'm going 17 by 14, and then we're gonna go out to the 72. Something that I noticed yesterday, because on the last practicum, everyone seemed to be having a hard time getting the tube to like actually lock in. So if you're using the all release button, the light will light up, but it doesn't actually stop. If you're using just this one that's the back and forth, it will actually stop you there. I mean, you can push past it, but it actually like clicks in like it should. So keep that in mind. All right, so we're 14 by 17 here. I'm going to close my image receptor. So we talked about hand spread method as one way to find where you're gonna center. So you would put your thumb on the top of your patient's vertebral prominence, and then that's about 7 inches for most people. On females, we're centering 7 inches down from the vertebral prominence. Males, it's about 8 inches down. The other thing we can do is we can find those inferior scapular angles and go to the midline from there as well, because we're centering on T7. So we have a couple ways to get there. So I'm gonna have my patient go ahead and put her chest against the board for me. And I'm going to come up for sure, but let's see how far up I'm going to come. Oh, maybe not. Okay, the bottom of her scapula is right here. Down a little bit. All right, and then I want to make sure that my patient gets all the way to the board. So we're gonna roll your shoulders forward like you're all the way against the board. Perfect, and I'm centered on her spine. Arms kind of going around the board is a better, like you're hugging it, is a better kind of way to tell your patient to position, because if their arms stay at their sides, you could end up with soft tissue over the chest, or even like if they're really thin, their arms all the way in, okay? So arms around the board like that, make sure that the chin is up. Where did my markers go that were up there yesterday? All right, and then I like to use a left marker for both chest x-rays. For the PA, you can use left or right as long as you put it on the correct side, but if you use your left, then you don't have to change it when you go to your lateral, okay? So she's just like this. I'm gonna roll the shield behind, and then I always like to warn my patients not to step back so they don't trip over the shield because it's right behind them. And then take a deep breath in, blow it out, take another deep breath in and hold. So that double inspiration, okay? And then take your exposure. So that's our PA. I'll have my patient go ahead and relax while I go ahead and switch the image receptor to be lengthwise. Don't forget that you're switching to lengthwise. Okay. All right, so I'm still gonna stay at 72. But now I need to change my light field to be 17 top to bottom, 14 side to side. I'm gonna have my patient turn and face the left for me. And my marker can go here in this top corner, okay? And then I'm gonna have you bring both your arms up on top of the side V pole. Perfect. And then go ahead and step back for me. More. More. There you go. Okay, so when we're centering for the lateral, On females, you essentially can pretend that you're like chopping off the breasts because we want to center between the sternum and the posterior portion. So when we were doing T-spine, we were centered, I'm gonna move you a little bit. We were centered more like here, right? But on chest, we want to be centered mid-thorax, okay? And then I want to make sure I'm still centered here. I am gonna come down a little bit since our light field opened up top to bottom. So we're lined up here. Make sure you're all the way against the image receptor. Make sure that she's nice and straight. Make sure that the shoulders aren't turned one way or the other, okay?
And this is the one that you said had to be portrait or?
It's lengthwise, yeah.
Lengthwise?
So portrait, yep. All right, and then same breathing instructions. Deep breath in, blow it out. Take another deep breath in and hold, okay? And that's your 2 views of the chest. Another trick that sometimes helps with getting your patients back a little more lateral is to have them bring their elbows together. So when they're holding onto an actual like wall bucky handle that most places are gonna have, it's easier for them to bring those elbows together and it pulls the top part of the back into a perfect lateral. So it's easier to see if you have rotation or not. And it kind of helps self-correct that rotation, okay? So those are the 2 views for practicum. Let's go ahead, I'm gonna move this out of the way. We would still shield for these, but I'm gonna just get it out of our way. Let's look at the AP lordotic. So this one, we would change back to crosswise. And this is the one that the book tells us to have our patient step away from the bucky and then lean back. My method that I use is a little bit different than that because I feel like it's a little safer. I like to have my patient go ahead and put their back against the board and then keep your shoulders here, but I want you to take your feet a foot forward. Yeah, so then they end up leaned, but it's safer than having them go from here to leaning back, okay? So just like that, and then we're centering mid-sternum, keeping our chin up. So we're good right about there. I'm gonna open to be 14 side to side, 17 top to bottom. And remember, if we clip the costophrenic angles here, we're not as worried about that. And then we would put a right marker here, okay? So that's all that lordotic chest is. And this is where we're getting the clavicles up over the top of the lung field so that we're seeing those apices free of superimposition, okay? So you go ahead and relax. Now, the AP and lateral airway. So there's a couple things with this. In the field, you're going to see it called a soft tissue neck most of the time. So soft tissue neck means that sometimes they're even evaluating like the lymph nodes, or they want to see if somebody has like stones built up in their tonsils. They're wanting to see all of that kind of stuff. So they call it a soft tissue neck. We don't angle our tube. That is because if we're looking for a foreign body, we want to be able to see where it is in that airway. So no tube angulation, but we just make sure our patient's chin is up and out of the way. So we're going to go with a 10 by 12 lengthwise. I'm going to show you the lateral first because I'm already at 72. So my patient is going to come put her left side against the board again. And I'm going to fix this to be 10 side to side. Where am I? There we go. Top to bottom. And then with this, we want the top of our light field to be at about the EAM. So, wrong one. We're gonna close this a little bit. Make sure that your left shoulder is touching. And then right about there. We're centering, I think the book says C6, I think. And with this one, so we're centered here. We wanna make her bring her hands behind her back and lock them. That way we're pushing those shoulders back out of the way of the airway. And then breathing instructions for this is going to be breathe in through a straw so that we're filling that airway up. But unlike when we've used that breathing technique before, it's still a quick exposure. So it's not a long exposure because we're not trying to blur anything. We just want it to be air filled. So once they're breathing through that straw, it's just a quick exposure, and that's your lateral airway, okay? And then the AP, she would turn and put her back against the board. And we're going to come in. Okay, and come down a little bit. Come down here as well. And we're going to go on the 40-inch line, probably at about 10 right there. Leave it open side to side. Now with this one, we want to get the acanthomeatal line perpendicular to the image receptor. So that's the line, if you were to draw it from here to here, we want to make sure that that is perpendicular to the IR. So my patient brings her chin up, and we look from her EAM or the ear hole to her upper lip, and it looks pretty straight right there. Good. My marker's on the other side on the left still, and it would be the same thing. Just slow, deep breath in through the straw, quick exposure. Okay? So they're really not difficult views, and you guys will do these pretty often, especially on kids if they've swallowed something or like that. So, questions about those?